If you are over 60 and you open your pill organizer every morning, believing you are carefully protecting your health and extending your independence, you may not realize that each capsule carries both potential benefit and potential risk, depending on whether it aligns with your actual biological needs. After 60, your body changes in quiet but powerful ways that alter how nutrients are absorbed, transported, metabolized, and eliminated. Absorption in the digestive tract often becomes less efficient as stomach acid production declines and intestinal transport mechanisms slow. Metabolism in the liver becomes more sensitive to overload, especially when multiple medications compete for the same enzymatic pathways. Kidney filtration gradually declines, meaning excess vitamins and minerals may accumulate longer than they once did. Organs that once tolerated nutritional excess without consequence may now respond with subtle strain. Yet the supplement aisle grows louder every year, expanding in size and promise. Bright labels advertise energy, immunity, mental clarity, and youthful vitality. Very few highlight the importance of individualized dosing and laboratory confirmation. Research in aging populations reveals a troubling and consistent pattern. Many older adults are deficient in certain nutrients that genuinely matter for bone strength, nerve integrity, and muscle function. At the same time, many consume high-dose supplements they do not physiologically require. Deficiency on one side slowly erodes resilience. Excess on the other side quietly stresses organs and metabolic systems. That imbalance can accelerate rather than prevent decline. Today we will examine 4 vitamins that can become harmful when taken unnecessarily or in high doses after 60. Then we will explore 4 nutrients that often deserve attention when blood testing confirms insufficiency. This discussion is not rooted in fear. It is grounded in precision and biological awareness. Let us begin with vitamin E in high-dose supplemental form rather than food-based intake. Vitamin E, naturally present in nuts, seeds, and plant oils, plays an antioxidant role in protecting cell membranes from oxidative damage. However, large meta-analyses published in respected medical journals have associated high-dose vitamin E supplementation with increased all-cause mortality in certain populations. The SELECT trial reported a higher incidence of prostate cancer among men taking high-dose vitamin E supplements over extended periods. Vitamin E is fat-soluble, which means excess accumulates in tissues instead of being rapidly excreted. High intake may interfere with normal clotting mechanisms and increase bleeding risk. In older adults taking anticoagulant medications, this interaction becomes clinically significant. The conclusion is not to eliminate vitamin E from the diet. The conclusion is to avoid high-dose capsules unless specifically recommended and monitored. The second nutrient to approach cautiously is performed vitamin A in the retinol form. Vitamin A supports vision, epithelial health, and immune response. Yet when consumed chronically in high supplemental doses, retinol accumulates in the liver. Research published in major medical journals has linked long-term high intake with increased hip fracture risk in some populations. Excess retinol interferes with vitamin D signaling and calcium balance. Rather than strengthening bone, imbalance may weaken skeletal integrity. Safer alternatives include beta-carotene from colorful vegetables, which the body converts into vitamin A only as needed. The third nutrient requiring caution is iron taken without confirmed deficiency. Iron is essential for hemoglobin formation and oxygen transport throughout the body. However, many older adults, especially men and postmenopausal women, do not require additional iron supplementation. Excess iron promotes oxidative stress through free radical generation. Gerontology research has associated iron overload with elevated risk of cardiovascular and metabolic diseases. Iron accumulation develops gradually and may damage the liver, heart, and pancreas over time. Fatigue alone is not sufficient justification for iron supplementation. A ferritin level and complete blood count should guide any decision regarding iron intake. The fourth vitamin to monitor carefully is high-dose vitamin B6. Vitamin B6 is water-soluble. Yet chronic intake above 100 milligrams daily has been associated with sensory neuropathy. Neuropathy may present as tingling, numbness, or burning sensations in the extremities. For seniors already vulnerable to balance issues and falls, nerve irritation adds unnecessary risk. Many energy blends and multivitamins contain substantially more B6 than required. After 60, the daily requirement remains modest at roughly 1.5 to 2 milligrams. More does not enhance function and may instead impair it. Now let us shift toward nutrients that often warrant evaluation for insufficiency. First is vitamin D3, which behaves more like a hormone than a simple vitamin. With age, skin synthesizes less vitamin D in response to sunlight exposure. Reduced outdoor activity further limits natural production. Low vitamin D levels correlate with reduced bone density, increased fall risk, and possible cognitive decline. Population studies consistently report widespread insufficiency among older adults. Vitamin D regulates calcium absorption and contributes to muscle contraction efficiency. Testing serum levels allows tailored dosing under medical supervision rather than guesswork. Second is vitamin B12. After 60, declining stomach acid impairs B12 release from dietary proteins. Lower intrinsic factor production further reduces absorption efficiency. Deficiency may manifest as anemia, neuropathy, cognitive changes, and gait instability. Estimates suggest a substantial percentage of seniors have suboptimal B12 status. Supplementation through sublingual preparations or periodic injections can bypass gastric limitations when necessary. Correcting deficiency often leads to meaningful improvements in clarity, coordination, and energy. Third is vitamin K2, a form less commonly discussed but physiologically important. While vitamin K1 primarily assists blood clotting, K2 directs calcium into bone rather than arterial walls. Observational research associates higher K2 intake with reduced arterial calcification and lower cardiovascular mortality. Many Western diets lack fermented foods that naturally provide K2. When combined thoughtfully with vitamin D3, K2 may help optimize calcium distribution. Fourth is magnesium, technically a mineral but central to hundreds of enzymatic reactions. Magnesium supports muscle relaxation, nerve conduction, glucose regulation, and blood pressure stability. Dietary surveys indicate that many older adults consume less magnesium than recommended. Low magnesium levels have been linked to increased risk of diabetes, hypertension, and arrhythmias. Increasing magnesium through leafy greens, nuts, seeds, or supervised supplementation may correct deficiency when present. Across these 8 examples, a consistent theme emerges. Your body after 60 benefits from measured correction of documented deficiencies rather than indiscriminate megadoses. Laboratory evaluation provides clarity that marketing claims cannot. Before adding or removing any supplement, consult your healthcare professional and review current medications and kidney function. Individual needs vary widely based on medical history, dietary patterns, and metabolic health. The objective is not to eliminate supplements entirely. The objective is to use them intentionally and proportionately. Open your pill box tomorrow with curiosity rather than habit. Ask whether each capsule addresses a documented need supported by evidence. Ask whether recent blood work validates its continued use. Your independence depends not only on what you take, but on why you take it. Longevity is built on precision rather than volume.